Hi everyone, I'm Jack Cush with Room Now. I'm joined by three friends to discuss the polymyalgia rheumatica giant cell arteritis happenings at EULAR2020. I'm joined by Dr. David Liew from Austin Health in Melbourne, Sarah Mackie at Leeds in the UK, and Len Calabrese at the Cleveland Clinic. Good afternoon, good morning, good night. We're in so many different time zones here. It is the way of the world. So we're going to discuss some happenings on the PMR GCA front. David, why don't you take the lead and introduce our first abstract?
Absolutely. Well, there have been some really exciting abstracts, I think, at this EULAR that have challenged the way that we think. I think in particular, one of the things that I think all of us would nominate as something which we've been looking forward to seeing is extension data from GCA. GCA, of course, being the key registration trial for tocilizumab and giant cell arteritis. And what we saw at this conference was some of the data that's come out from subgroup analyses or from the extension data. So in fact, going out to 3 years now. So one of the key bits was that 3-year data, which was presented by John Stone from Mass Gen, that's OP0027, with data looking at steroid utilization and flare rate in the different groups of GCA. So that's a weekly, every 2 weeks, and then the placebo group from that study. I mean, I'd be curious to know, to get some thoughts from the group about that. It's such an important study for our use of tocilizumab in giant cell arteritis.
Sarah, what do you think about that?
Well, I think this 3-year data is really, really exciting. It's in a way even more exciting than the 1-year data, which resulted in the licensing of tocilizumab, because it starts to answer the question whether good control of inflammation in the first year of treatment for giant cell arteritis matters for long-term outcomes. And additionally, there's the relapsing subgroup. So if you then have 1 year of really good control of inflammation, does that then cause better long-term control on so they did an intention to treat analysis, and they looked at the percentage of patients remaining flare-free through the whole years 2 and 3 of the study by their original treatment allocation. And they also looked at the median time to flare. It was really, really impressive that the patients who were originally allocated weekly tocilizumab had a much greater chance of remaining flare-free throughout years 2 and 3 compared to those who were allocated placebo, and then the 2 weekly tocilizumab was somewhere in the middle. So this is absolutely fascinating, because for a long time in inflammatory arthritis, we've had discussions about window of opportunity, about the importance of tight control, but until now we haven't really had that kind of data in giant cell arteritis, that good control of inflammation actually then has long-term benefits.
So Lenny, what do you think about the GCA and especially the long-term data? Is it enough to change the habits and practices of rheumatologists? It's been slow on the uptake in actual use.
You know, I consider it a standard of care. And, you know, I think that we'll talk about steroid toxicity in a bit. But I was impressed that we've learned or reaffirmed this is a chronic disease. It's not going away. And the other thing that I would say, Sarah, I would say that the every other week is not in the middle. It's pretty darn close to the weekly. And I've been using a lot of every other week, you know, trying to risk mitigate. And, you know, I don't think we have the final answer right now on, you know, how many people we can control, but I'm in for the long run, and if I can get away with every other week, I'm very happy to do it.
David, what about you in weekly versus every other week?
Well, I think that the relapse data from this extension, in that 3-year extension, really has started to make me think maybe I should be thinking about on weekly for my patients. In Australia, we get 1 year in total of weekly dosing, so we get 52 doses. And it's made, I've often thought about, well, for some of my patients, I've been spreading them out, trying to do it every 2 weekly, thinking about that data. But I think this has made me think a little bit more about that, and also has made me think a bit about, you know, whether we really should be advocating for more tocilizumab access for our patients. But ultimately, it's a steroid-sparing benefit, and it's the benefits there early on. I mean, what would you say to that, Len? Yeah.
Let me be clear. I start with weekly, and I'm talking about the long run now, year 2, year 3, and beyond. I think there's a case to be made that we need to look more carefully at dose reduction in that group, and I think it works pretty good.
I mean, yeah.
David, what about the abstract on PET CT? Does that make us smarter in our management of GCA? Can you tell us about that?
Yes, and I particularly like this because it really, this is work from, sorry. I think it's stored up there. This is work from Peter Grayson at NIH, or his group, and looking particularly at what happens after throughout the course of tocilizumab therapy. So I think as Len was mentioning, or as Len's talked about, there's ongoing tocilizumab therapy there. They looked at 22 patients, and they did, I think, what seems pretty remarkable to me, in that they did a PET CT at baseline, and then every 6 months after that, which I don't think we'd necessarily do for routine care, but it gives us an idea as to what the kind of FDG vascular uptake, how that trends over the course of time. I think we're starting to understand that more, and we're seeing that in a few of the other abstracts, that may well represent real disease activity. But what I think was interesting out of this was that they tracked it over 2 years, and we could keep on seeing that FDG uptake, that scintigraphic uptake representing inflammation in the vessel, keep on dropping over the course of time. And what's more, they looked at some patients where they withdrew the tocilizumab, and then they saw them flare as well. So, I mean, for me, that's quite a stunning finding, to be able to see that there's benefit over 2 years. But this isn't the kind, I've always thought, once again, maybe because of my paradigm in clinical practice, that a lot of that benefit comes from the first year. This is where we see the steroid-sparing benefit. But it does seem that this is something that keeps on going and going and going.
So is this just a research tool, Sarah, or is this something that has practicality?
I guess it's whether it's going to change your clinical decisions at the time. There is this disconnect between the systemic symptoms of giant cell arteritis, the inflammatory markers of CRP and how patients feel, and then what's going on in the vessel wall. And without doing serial biopsies, really imaging is the only other way to monitor what's going on. I think other people have used serial ultrasound, but clearly that you can only access a limited number of vessels. With that, you can't get to the aorta to see whether there's kind of ongoing disease activity there. So I think at present, we're still finding our way as to how much vascular imaging monitoring is required in these patients. But I think when you get to clinical decision points, imaging is often very helpful.
Lenny, at the clinic, you guys are one of the worldwide leaders in vasculitis care. Does FDG PET fit into your use and assessment?
Well, it sure fits into the diagnostic algorithm. I mean, nobody does bilateral temporal artery biopsies anymore. And if you have access to it diagnostically, I think it's very sensitive and helpful. I think that, to me, this abstract reaffirms, A, this is a chronic disease. It's not going away. But as Sarah said, is this actually going to change practice if you could do this? And, my knee-jerk response is that, no, it wouldn't change my practice. And the real question is, what is the end game? What would it look like, 8 years out? I suspect there'll still be low-grade inflammation there. And I think this is Len being crazy, that, this is going to kind of anneal itself with chronic low-grade inflammation of aging, inflammaging. And I don't think it's ever going to go away. And these events of aortic aneurysms and stenosis, they're really rare. Yeah, I mean, and all of these people demonstrate this. So I find this pathophysiologically fascinating, and leaves me in a quandary as to how it would work as a clinical tool, but it also gives us great insight into inflammation and aging.
Good. Let's move on to the abstract on PMR, and what may be lying underneath that in the form of vasculitis. David.
Absolutely. Well, this is one that I first heard talked about at the PMR GCA study group, but I think has real implications. So this is from a group in Bonn, Valentin Schäffler's group in Bonn, who they took PMR patients, 50 consecutive PMR patients presenting to their clinic, and really tried to address this question: what's this relationship between PMR and GCA, and where does it sit, and how many of our PMR patients? Well, we think eventually 20% of our PMR, about 1/5 of our PMR patients, might go on to develop clinical GCA. But where does that relationship start at the beginning? Is it there all along? We're not picking it up? How does it develop? So they performed vascular ultrasound on all of their 50 consecutive patients. So we wouldn't think that beyond what's coming into that tertiary centre that would necessarily be selection bias. And what they saw was that 27 of those 50 had vascular uptake outside of limits which would be consistent with giant cell arteritis. Of those 27, 17 had symptoms which could be culpable, which could be attributable to GCA, which does sound high to me. But then another 10 had no GCA symptoms at all, but still had that uptake. So I'm not really sure what this means. Is this part of giant cell arteritis? Is this subclinical giant cell arteritis going on there? Does this become giant cell arteritis in the end or not? I'm still uncertain where that relationship comes about, and does it need a 2 hit to, do PMR patients need that second hit to develop giant cell arteritis in the future or not?
So Lenny, this is another more sensitive way of finding what we've always been told in the past, that it could be there, but you don't necessarily treat it. Does this make you more inclined?
There's nothing new under the sun. This is the same question that's been asked for the past 50 years in this disease. And, I love Valentin. He's a very careful observer, and this just reaffirms everything that I've ever thought about this disease.
So be careful what you ask for. Sarah.
So, this is a question which I've been fascinated by since I first started PMR and GCA, and Colin Pease and I looked in our LEADS data set, looked at these patients who were originally diagnosed with polymyalgia rheumatica and then went on to develop giant cell arteritis later. And we were trying to work out, did they always have giant cell arteritis that was just hiding, or did they actually then develop this, like a 2-hit, this second disease? And was there subclinical giant cell arteritis? And of course, at that time, we didn't do routine vascular imaging at diagnosis. And so we didn't know. We still don't know, because in clinical practice, we don't necessarily do that. But this would support the idea that, at least in some patients, polymyalgia rheumatica patients do have a subclinical giant cell arteritis from the beginning, that you can pick up if you look on ultrasound. And maybe these patients, you would need the long-term follow-up data to know, but maybe these patients are the ones we should be watching really, really carefully to see if they then develop clinical giant cell arteritis requiring high-dose steroids. And we should maybe be treating polymyalgia rheumatica a lot more seriously as a pre-disease state, not as a little category all by itself that could just go back to the primary care physician. But actually, these patients are high risk for developing giant cell arteritis, and we should be taking this seriously.
So this is in line with what Lenny was saying, that this is a chronic disorder, and we got to be in it for the long haul in our assessment of these people. Let's end up with the effect on PMR and steroids. David.
Absolutely. Well, this is. It's industry initiated, but I think it has a really important message, and I think it's been done reasonably well. This looks at claims data, US claims data, in patients with a diagnosis of PMR, and then looks beyond that at that first year to see what incident potentially steroid-related complications accrued in that period of time. So we're talking about substantive numbers of patients. We're talking about it was over 12,000 patients. PMR patients had very well matched controls at that time, and then they looked to see what complications they developed. And you can see right across the board that they kept on accumulating more and more complications. Now, it's hard to know, is this disease, is this a steroid? It has a guess that it's more likely to be the steroid, but I can't say that for certain. But I think what's really telling is that I think people often dismiss the 15 milligrams of prednisolone that you might have for polymyalgia rheumatica as not harmful. I think people perhaps maybe even undervalue PMR as a disease. think of it as incidental or self-limiting. It was still a disease we don't have steroid-sparing therapies for that have been proven in a phase 3 trial. And so we're left in a situation where these patients are getting more hypertension, more diabetes, more infections, more cardiovascular disease, more skin toxicity and neuropsychiatric disease, ocular disease, renal problems, things that we wouldn't, that might easily get forgotten in terms of thinking about PMR as a real disease.
So this is the age-old question in managing, especially PMR. You know, how can we minimize or avoid steroids? Are we going to get to the point where we should be using tocilizumab in PMR, or the C5a inhibitor, avacopan, that was for the ANCA-associated vasculitis? Where should we hold tight to steroids, or should we be looking to the future and substitutes? Sarah.
So I think we desperately need some good trials of steroid-sparing agents for polymyalgia rheumatica. This is not a benign disease. So for the patients that can get off steroids quickly and without complications, that's absolutely fine. But there's a substantial, so it's not even a minority, who require 2 or more years of systemic steroids, and they accumulate the most awful panoply of side effects, some of them. And we just have no decent evidence as to what we should be giving these patients to help mitigate that. And we should be going in much earlier, I think, and thinking about what to give them. But I think it's been challenging to get these trials funded. It's been challenging to get these trials designed because historically they have the classification criteria for polymyalgia rheumatica. There were lots of different sets and it was confusing. And also some criteria for relapse and remission needed definition. But all these things are being worked on now, and I think this just really underlines the need for a decent trial of something that can help our patients with polymyalgia rheumatica. Yeah.
Len, what's your perspective on this?
Prednisone is poison. And,
many years ago, I came up with...
I didn't say that. It's not my quote, as you know.
But many years ago, I came up with a trial, greatest acronym I've come up with yet, called the PRADA trial, polymyalgia rheumatica and adalimumab. And you know, we ran it around. It was obviously the companies loved it, but you know, the old guard, you know, Harry Spira and a lot of the guys that are the PMR guys, they were like, "What are you out of your mind? You're going to use $1 million drug when you can spend 12 cents on prednisone?" This is what we're up against.
It sounds like. No, I agree, but I mean, there's been some great advances now in steroid sparing. You mentioned avacopan, and actually AbbVie has a bispecific antibody with adalimumab and an intracellular steroid antagonist that anneals to the same cell. I mean, yeah, these are expensive bioengineered drugs, but you know, I guarantee you that, you know, 5 years from now, we're going to be doing something a lot different in this area. We got to keep pushing. I'm so excited about the avacopan data. I think that's, you know, just the total game changer it's going to be, and it gives us. No one would have dreamed of that, you know, a decade ago. So,
David, why don't you just briefly go over that data, because it was a highlight from the meeting.
Absolutely. I mean, in my mind, it was probably the highlight of the meeting. So that's avacopan in that phase 3 trial. Also got presented at the European renal meeting as well on Sunday by David Jane. But Peter Merkel presented the data looking at patients with ANCA-associated vasculitis who were getting either rituximab or cyclophosphamide, and compared in a double-blinded randomized controlled trial way steroid versus avacopan. And the outcomes are fairly stunning. We saw that there was non-inferiority at 26 weeks. The patients went on, had superiority at 52 weeks, better renal outcomes, obviously less steroid toxicity. I mean, this is going to be a great new advance. And I mean, to be able to have the chance to use this would be fantastic.
But unfortunately, it's going to come at a price. Right? And that's the big worry, right? Anyway, this is really stimulating. I want to thank all of you for taking the time out to discuss these important abstracts. There'll be more on EULAR to come, I assume. So good day, everyone.
Thank you.
Thanks so much.
Thanks.
Stay safe.